Hello, my fellow pharmacology adventurers. Today we're going to talk about COPD pharmacotherapy. A lot of this has overlap with the asthma lecture you've already listened to. There are some specifics related to COPD, but you'll find a lot of familiar territory here. Like asthma, COPD is classified with severity, and we choose pharmacotherapy based on this patient's severity of symptoms. So we're going to talk about the key tools that we use to classify patient symptoms, common risk factors associated with COPD. Then we're going to start recommending appropriate medication and non-medication therapy for COPD. And then we'll talk about the drug interactions and specific patient education points you need to include when you prescribe these medications. Well, you already know that COPD stands for chronic obstructive pulmonary disorder or disease. It's a chronic inflammatory response to the environment, to particles in the airways and the lungs. It is a progressive and debilitating disease, and by nature, it is irreversible. That is one of the ways we distinguish it from an asthma diagnosis, is that asthma can be reversible and COPD is not. Asthma puts a patient at risk for many different other diseases, some related to the disease itself and some related to the medications that we use to treat it. Just a list of those here: cardiovascular disease, osteoporosis, skeletal muscle dysfunction, depression, anxiety, metabolic syndrome, lung cancer. That's definitely a long enough list. And other circumstances that can make COPD worse is GERD, acute infections, the weather, and air pollutants in our environment. As we talk about COPD, let's remember a case as we go forward. Let's talk about Eddie. He is a 60-year-old male. His chief complaint is, I keep getting short of breath when I walk upstairs. He can't walk around his house and to the mailbox anymore without resting and if he does, he gets short of breath. About a month ago, he reported he had a COPD exacerbation, but he didn't require hospital admission at that time. So based on what we know of Eddie, how would you assess his overall symptom severity and disruption of his life that is caused by his COPD? Let's talk about that. Usually patients present with COPD symptoms with a cough, with a productive cough, specifically sputum production, dyspnea upon exertion, that sounds like Eddie, doesn't it? Airflow limitation that is measured by spirometry, and impaired gas exchange. So that would be a low O2 sat. The organization that codifies the treatment guidelines for COPD is abbreviated GOLD, G-O-L-D. That stands for the Global Initiative for Chronic Obstructive Lung Disorder. You can find their most recent guidelines at goldcopd.com. Those are available to the public, and you can log in to get those updated guidelines at any time. When we're treating COPD patients, we have some treatment goals in mind. The first of those is that we want to relieve and reduce the patient's acute symptoms. Longer term, we want to improve the overall quality of life, improve exercise intolerance, improve overall health status. And then in another category, we want to reduce the risk of future events. So that means preventing and treating complications, reducing overall morbidity and mortality. Basically, we want to achieve maximal benefit from our medications with minimal side effects. There are several tools that we use to assign patients to an acuity level for their symptoms and exacerbation of COPD. One of those is called the MMRC. Another tool is called the CAT score. It's not important that you know the specifics of those, but the way that we categorize those patients based on their scores is as follows. With the MMRC, if they have a score of 0 to 1, they are in the A or C category. And we assign A or C based on how often they have a hospitalization related to their COPD. With the CAT score, slightly different tool to categorize patients, and that score would be a less than a 10. Again, it's not important to know the specifics of the scoring, but just seeing how we categorize patients and then choose therapy. On the other side, the MMRC of 2 or over, a B or D is selected, and then based on the increasing number of hospitalizations, then that's how we choose between the two. The CAT score over 10 would also indicate that. Once we have an idea of where the patient falls in that grid, then we can start to select medications. If they're in that group A, the lower left corner, then their treatment probably just involves a SABA or a SAMA. Now, if you recall, a SABA is a short-acting beta agonist. That is your albuterol and levalbuterol. And the SAMA is a short-acting muscarinic antagonist. That is ipratropium. Both of these work to improve breathing function, lung function, reducing symptoms, decreasing dyspnea. Now, for patients who are in group B, that is the lower right-hand corner of the grading grid, we select a LABA. If you recall, that is a long-acting beta agonist. That helps improve symptoms and lung function, but on a longer-term basis. We also have LAMAs, which is a long-acting muscarinic antagonist. Those also do the same thing as LABAs, decrease dyspnea, help with lung function. And often we'll use these two things in combination products. There are a lot of single agent products on the market, and this is a summary of what you will find in the United States. Some of them may be also available under a different name in Canada. But here we have the formoterol, the indacaterol, olodaterol, salmeterol, and arformoterol. All of those have different brand names, but pretty much the same indication, maybe a different dosing frequency. You can see a summary of that in this box. For patients who have a lower score but higher number of hospitalizations related to COPD, we try to add on a LAMA if they don't have one already. And then for those patients in the group D, that's the top right corner of our grid, those are patients who have higher number of symptoms and a higher number of hospitalizations. At that point, we definitely need to have them on a LABA plus an inhaled steroid, or you could go with a LAMA plus a LABA. The drug of choice in this case would be adding the inhaled steroid with a LABA. There are a lot of these combination LABA plus steroid products on the U.S. market. This is a summary of the products that we have with their brand names. Most of them are BID dosing. There is the one, the fluticasone furoate, that's the Brio Ellipta brand. It is a once-a-day dose. And that was our short review of the pharmacotherapy associated with COPD patients. Most of this is an overlap with asthma, and a lot of the products are the same. And like asthma, we gauge our therapy on the patient's symptoms and number of exacerbations.